Good afternoon, and welcome to the Obtaining the Best Possible Medication History conference call. My name is Zanera, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Ms. Jody Ross. Ms. Ross, you may begin.
Thank you so much, and thanks for being our operator for today. It is my pleasure and honor to be on the call and presenting today with Tony Tetner. I want to thank everyone for taking their time out of their day to join us for our first part of a four-part series on medication reconciliation. And as it was already stated, please note that we will save all questions to the end. Please feel free to put them in the chat function at this time. All lines are muted, and we'll continue that way until the end of the call. Again, we really appreciate your attendance. I'm going to start with reading you information about the continuing education credit. Thank you, attendees, for being at this presentation. Because Medistar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planner conflicts of interest. For CE credit or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive at the end of this WebEx. We encourage everyone to complete the evaluation to provide feedback on this session. And you will also have a CME disclosure attestation form, and we really appreciate that your attendance and your interest in continuing education credit. Now, without further ado, it is my pleasure to introduce Tony Tetner, who is our medication safety expert at Medistar, who joined our team with expertise in all settings in a leadership role, most recently in home health, and has a lot of experience working on multidisciplinary teams and implementing evidence-based care.
Well, thank you very much, Jody, and thank you, everyone, for attending today. This is very exciting, not only for us at Medistar, but we hope that it will result in some really improved processes in each of your settings, and that we'll be able to provide some data at a future date with respect to that. So just to start us out a little bit, before we actually get into this webinar series itself, I'd like to just take a moment to talk about our ADE work here at Medistar. And ADE is referring to adverse drug events. And so if you go out and take a look at some of the literature, it's very much important that we begin to have dialogue about adverse drug events and their effects on patient outcomes, no matter what the setting is. There's a really good piece of manuscript out there that's from the Health and Human Services, the National Quality Strategy and Plan for Decreasing ADEs. And there are lots of goals, pretty hefty goals around a lot of this work in terms of decreasing the number of ADEs by, 20% in the next couple of years. So that's going to require that all of us are working really hard to be able to do that. And we all can know that our goal across the board is to prevent harm in our patients, again, no matter what the setting might be. And we can do that by decreasing adverse drug events, by decreasing the hospitalization, utilization, the number of admissions and readmissions occur that are related to adverse drug events, and then therefore improve outcomes, it's cost savings. So there are a whole lot of really good rationale for having discussions about adverse drug events, and of course medication reconciliation, medication safety is paramount to that. The other couple items that I wanted to just mention to you are, when you registered for this event, there was a baseline assessment that we were asking you to complete. And if you took a look at that, there were 9 questions related to your current process around medication reconciliation. And we strongly are asking you, encouraging you, if you have not completed that baseline assessment, to do that. We are going to hopefully use this as an evaluation measure for our work with CMS to be able to document that across the state there's been improvement in medication reconciliation processes. But we're also encouraging you to fill it out because we will be able to, if you do, give that data back to you to use internally to support whatever other work you may be doing, with other organizations. So that could be the Joint Commission, it could be regulatory agencies and bodies, it could be your own quality improvement committee, board, leaders, leadership. So if you have any questions about that, you can ask perhaps at the end of this, or you can email me, and I can help you work through that. The other thing that's a little bit different from the baseline is immediately following this webinar, you're going to receive an evaluation, and that evaluation has to do with the content and the delivery of today's event. So they're two separate things, and I just wanted to make sure that I took a little time to clarify that. PowerPoint slides are available online when you registered. Again, if you're having problems with those, we can work through those. And then you may want to, if you haven't already, since subsequent webinars are going to talk about and work with the MATCH toolkit, M-A-T-C-H. We provided some links for you. You can go ahead and also, I would encourage you to download that for the further discussions. And again, that's a publication. It's on the AHRQ website, and it's very easy to retrieve and download. So without further ado, we'll begin today's presentation. And today is sort of a higher level overview. It's just getting us to think about the medication reconciliation process and just to kind of start to think what that might look like and how we might be able to affect change in each of our organizations. So today's presentation is that we're going to define medication reconciliation and its purpose in terms of med safety. We're going to talk about the benefits of medication reconciliation, identify barriers and obstacles in performing this very intensive process that we're all very aware of no matter what our setting might be. And then we're going to talk about some effective interviewing strategies to improve that reconciliation process. So just a few of the different the definitions that are related to medication reconciliation. So the Centers for Medicare, Medicaid, and the Institute for Healthcare Improvement talk about it as being a process of identifying the most accurate list of all the patient's medication. And that includes what the name might be, the dose, the frequency, and the route. And it's done by comparing the medical record to an external list of medications obtained from the patient, the hospital, or other providers. So I think that definition really is inclusive. It gives us all, we all have the capacity to be able to affect the medication reconciliation process, and across transitions, we all know it's just a huge piece of that. The World Health Organization defines it, again, as a process in which healthcare professionals partner with patients to ensure accurate and complete medication information transfer at interfaces of care. And again, much literature is out there that really addresses and talks about the number of adverse drug events and issues with medication reconciliation that occur from a transfer from one healthcare setting to another. The Agency for Healthcare Research and Quality, which has the MATCH tool, defines it as a complex process that impacts all patients as they move through all healthcare settings. It's again a process that involves comparing the patient's current medication regimen against admission, transfer, discharge orders, patient drug list, what the patient is telling you, what the patient's family or caregiver is sharing. So it really is a very complex process, and I know that that is not a surprise to anyone. I've done medication reconciliation in hospitals, in hospice, in home care, and in long-term care, and it can literally take hours to ensure that you really do have an accurate picture of what the patient's medication record really, should be. The Agency for Healthcare Research and Quality also indicates that the study data shows that an effective process can detect and avert most medication discrepancies, potentially avoiding a large number of adverse drug events and related costs that we know have a negative impact on patient outcomes. And I think the important piece there is that there is a lot of ability that we have to be able to prevent these from happening in the first place.
Great. Thank you, Tony. It's always a great opportunity when we have something that's under our influence and control and we can make a difference on those that we're caring for. So med reconciliation is a great opportunity to really help prevent harm and help promote the great care that you all provide. So thank you for doing so. We're going to talk a little bit about the purpose of medication reconciliation. You know, all of you are within your profession to be able to serve and make an impact on the quality of care, and medication reconciliation is a great way to do that. Adverse drug events are a serious public health problem. It's estimated that over 82% of American adults take at least one medication, and 29% take 5 or more medications. We know that over 700,000 emergency department visits and 120,000 hospitalizations are due to adverse drug events annually. It can be a great way to look at reducing your admissions and readmissions into your hospital setting and working with your partners across healthcare settings. That may help impact the cost that is currently spent on adverse drug events, which is over $3.5 billion on extra medical costs of adverse drug events. And at least 40% of costs of ambulatory settings, so physician offices and outpatient settings, are related to likely preventable adverse drug events. So it's a great opportunity to look at why is it occurring, what can we do to prevent this, and really make an impact in care and in our data potentially too. So the effectiveness of a sound medication reconciliation process among all healthcare settings is an essential component of safe patient care. It's also essential to keeping the patient in their own bed, keeping them in the setting that is least restricted to that person. It provides a framework to improve efficiency and save time and cost. And again, the estimated cost of a preventable adverse drug event is estimated to be about $4,800 per event. So it can also be a great value proposition to take to your teams to show that really focusing on med reconciliation as a process and really focusing time and energy on looking at adverse drug events in your setting and if they're occurring, and if they do occur, they're likely costing close to $5,000 per event, can be a great way to impact a lot of different resources as well. So the benefits of medication reconciliation is that it reduces work and rework associated with the management of medication orders, and that is probably something that many of you can relate to. You know, having the medications accurate and appropriately listed and then being able to administer those appropriately. Most of us have had challenges with that within our own healthcare settings. So think of a caregiver, that patient, and how difficult it is to understand that you're on the right medication and what we can do to really provide them with some lasting resources within their home by taking the time to do the medication reconciliation. And I think it's one of those activities that if you don't spend the time on the front end, it really comes back on the back end, and it can be less impactful and have more adverse outcomes. So we want to focus on positive patient-centered care and positive outcomes, improving patient satisfaction, and really looking at reducing those transitions that may not be necessary. And I love this visual of what medication reconciliation looks like, and because it really reiterates the purpose and the power of a good medication reconciliation process. So it really promotes medication reconciliation will promote that medication safety, it will reduce costs, improve outcomes, and also help you to get reimbursed for your hard work. And this is all part of a comprehensive quality initiative. Tony has done a lot of planning to make sure that you could take this as a quality improvement initiative that would meet all of the purposes of the quality payment program as well as other regulations.
Before we move on to the barriers, I just wanted to reiterate a little bit the work here that we're doing with adverse drug events, or ADEs as we typically refer to them, really has to do with 3 high-risk medication categories, and I'm sure you would all agree, and you probably, if you didn't know that, could easily probably figure out which ones those are. So those are anticoagulants, diabetic agents, in terms of looking at hypoglycemia, although hyperglycemia is also an issue, and then opioids, and again, there's a lot of work across the state being done on reducing opioids and in all healthcare settings. So I just wanted to reiterate that, and I'm sure we can all also agree that we have multiple patients who are taking all 3 of those medications and many more that have the impact to cause other adverse drug events from occurring. So let's talk about some barriers to performing medication reconciliation, and I kind of alluded to some of those before. So really, in order to have an effective medication reconciliation process, we really need to have a patient or a family or a caregiver who's really engaged in the process. And many of them often lack an awareness about their medical conditions and their medications. And again, I know we've all been in the situation where somebody has either brought their medications in, or we're sitting in their home or in the long-term care setting or the hospital trying to figure them out, and they're like, well, I take this little white pill and I think it's for XYZ, or they bring out this big bag of medications and you're trying to figure out and sort through what they have and what they don't have, and they're not sure what they have or what they don't have either. And again, they lack an awareness of their condition. Sometimes they lack an awareness of how it impacts other conditions that they have. So that's a huge piece of that. And I think health literacy has a lot of impact on that, and we're going to talk about that in some sessions to come. But just a word about health literacy. Really think about when you are producing materials for a patient. 2 things I think that have really had a huge impact on me lately as I've been researching health literacy and its effect on patients. Just because they can read something does not mean they can comprehend it. Most folks that are age 65 and over have really a low level of literacy. We're talking about the 3rd grade level. The other thing to consider, which I just read about the other day, is if I tell you that I have a 9th grade education, you can estimate at least that I can read at about a 3 grade level, less than that. So just because I graduated from the 9th grade or completed 9 grades doesn't mean that I can read or comprehend at a 9th grade level. It's probably more like a 6th grade level. And that just blows my mind away when I think about how we're approaching our patients or our residents or wherever they might be. So just something to consider for future reference. It takes a lot of time to perform a good medication reconciliation process. Just recently I came from home care, and I went out with the nurses, and I saw them taking literally 2 hours to complete a medication reconciliation process. I have been in a long-term care setting where I was the person doing that, and again, you're just spending a lot of time. So that's a huge barrier because we all have multiple things to do. We wear multiple hats, and now we're expected to do this. But if we don't do it, the question is, who is going to do it? And the focus has been on kind of completing the form or entering data into an electronic health record, I think, rather than sort of meeting more of the intent. And again, I think that goes back to providers, the nurses, the medical assistants, who's ever doing that. The nurse is, you know, they have time constraints. They just want to get through. They want to make sure they, you know, are putting all of this into the system. And so it's really more focused on getting things into the medical record than actually having a dialogue with the patient about what they think that their medications are and what they know about their medications. And again, that all takes time. So I think that as we're looking as a society, as a healthcare, you know, in a larger context, we really need to think about that moving forward. And be able to build in some kind of structure that allows for that to happen. And that's easier said than done, I know that. So, and then providers are often reluctant to order medications that are prescribed by others, and I think that can often also be a barrier to good medication reconciliation. So I think the next slide coming up really kind of says it all. And again, if you think about that, that's huge. So no matter how much time we spend trying to get to the root of what the medication list really should be and what it is, it seems as if there's always something that we don't have access to, or the patient has some meds stuck in a drawer or in their purse somewhere, and, we don't know about them till a later point they happen to pull them out, and hopefully it's not when the surveyor is present, and, you're trying to figure out what really is going on. So I think that's just a huge piece to kind of keep in the back of your mind. So in initiating a good medication reconciliation process, you want to use all the resources that you have available to you. So those can be current orders that you may have. Those can be any medication list, whether it's a list from a hospital or a list from a home health agency or from a nursing home, discharge summaries, history and physicals, consultant reports. They all have valuable information in them. The patient's list is also very important. And again, encouraging patients to bring their list and even to bring their medications in can often help us get to the root of what exactly it is that they're taking and why they're taking it. So requesting that patients bring medications with them, to their appointments, especially if it's an outpatient setting, is really imperative. And then pharmacies, we cannot forget the pharmacies, the local pharmacies, the hospital pharmacies, wherever the pharmacy might be. Those folks have additional information that is huge and very important. So knowing where the patient gets their medications filled, and unfortunately, it may not be just one place, it could be several places. Family members and caregivers are also very integral to the medication reconciliation process. So if it's possible to have them present, that always helps because they, spend time with that person, they know that person, they know their routines, they know a lot about their health literacy and what they understand. So using every possible piece of information that you can will go a long way in helping to initiate a medication reconciliation process. So getting to the techniques to improve the communication with the patient. And this is where we get a little bit more into that health literacy piece. So I think that the goal is that the patient feels a comfort level and that no judgments are being passed with whomever it is in whatever setting where you're trying to do a good medication reconciliation process. And I think that's huge. They are much more likely to divulge things to you if they feel that you're their partner and that you're there to assist and help them, as if you're passing judgment somehow that they don't know something or they're not sure about something. And this whole process, having a conversation with them, can also help you identify opportunities for education, or in terms of what their education, what their health literacy and level of understanding is, and then also what other assistance that perhaps that person or that family member or that the individual may need. So really very important. So, and just an aside, I think, and I know that I am very, this is me also as a patient, they tell us a lot of times what they think that we want to hear, not necessarily what the truth is. So that's always, trying to get to that can be somewhat of a challenge. So it's important when you're interviewing a patient, family member, or caregiver about their medications to try to use open and closed-ended interview questions to allow them the opportunity to explain what their understanding of things is, as opposed to, oh, I see you take, something for your diabetes. Oh, okay. So things like, oh, what do you take for your high cholesterol? Or do you take a medication for any high cholesterol? Do you take any medication for any diabetes? Are you taking any over-the-counter medications that when you get a headache, for example? Are all good questions and open-ended ways of allowing the person to have more opportunity to have a dialogue with you. Also asking questions that include information about the routes of administration. Do you ever take anything or put medication in your eyes or in your ears, or do you use any medication, that you're taking under your tongue, for example, if you're getting at something sublingual? So again, those are all, I think, good ways of putting questions that, again, sort of engage them and get them to think a little bit more about what it is they're really taking, as opposed to us just kind of going down this list that we have and using that as the mechanism for the conversation. Another way of approaching it is ask them about what they take for their medical, condition. So, what do you take for your, congestive heart failure or for your heart, or instead of using some kind of a cardiac-related term to really, kind of keep those terms really basic. Do you take anything for your blood sugars? Maybe is a better way of talking about it than even diabetes, or your blood pressure. What do you take for your blood pressure? Trying to figure out what other medications have been prescribed from other physicians, perhaps consultants. So does your asthma doctor, do they prescribe anything for you? Does the doctor that you go for your arthritis, do they prescribe anything for you? Are you taking anything that they've given you? And then ask patients when they take their medication. So this is really good at trying to get at, is this somebody who is real adherent to their medication regime, or are you detecting that there might be some concern about them forgetting to take their medication? Especially if it's something that's maybe monthly, like some of the osteoporosis medications that people take are only monthly. And I don't know about you, but I have enough problem just trying to remember to take the ones I'm supposed to take every day, as opposed to trying to remember I'm supposed to take something, every month. So I think that's really important. And then asking them if their physician has stopped or started any medication, or made any changes that they're aware of, or, added anything new in the last couple of, months, to see if they can, if they will, be forthcoming with anything that might have been added that way. It's also important to inquire about over-the-counter medications. So are you taking anything else that doesn't require or doesn't need a prescription? And you could maybe list some examples. And I don't know about you, but in home care, we would often find that one of our elderly patients was taking just about every herbal product that you could ever even, think of. And it's important to know those because so many of them, react with so many medications. I'm thinking anticoagulants in particular. A lot of those preparations that are herbal have an effect on either making your INR higher or lower. So really important to try to get at, what those are and, why it is that they're taking those. Again, asking, do you take anything to fall asleep? What do you do when you get a headache or you have a pain somewhere? And then also asking about the dose, the timing, or frequency, the strength, and the route. And I guess one thing I think people often forget about too is sometimes when people have valve replacements, they have to be put on an antibiotic for a dental procedure. Well, if I'm going to have a tooth pulled or removed, and I haven't had that happen for a very long time, am I going to remember that I have to do that? So it gets very confusing, and not only is it confusing for the patients, but it's also very confusing for us who are left with the task of trying to figure this all out. Just moving on, brand and generic names always, I don't care where we're at, create confusion for people. That's why it may be allowing them to express what they're taking in their own words is a really good idea. And again, just to remember that just because I also know what I'm taking doesn't necessarily mean that I'm engaged in my health care. So I think that's often the dilemma or the very difficult part. We have patients on all kinds of levels of engagement, knowledge, health literacy, and it's trying to find what works individually for each situation. We talked again about the health literacy. There's some really good tools out there that we just received from the health literacy conference that many of us attended here at Medistar. I also found some others, so if anyone is interested, I'd be happy, if you email me afterwards to send those to you. So if you want to take a look at any of the materials that you're currently giving to patients in terms of education, and you want to take a look a bit further to see at what level those are or how you might make those more effective, feel free to do that, and I'd be happy to send that to you. I think it's always a good idea, especially in the elderly population, to print off a copy of their med list, whatever setting you're in, and give it to them and encourage them to take it to the pharmacy when they go to get a refill or a new prescription filled, so the pharmacist can take a look at it and make a copy if they want, and they can sort of do the med rec there, kind of saving some time. Or if they go, to another consult or another physician, because the more we can empower the patients by giving them these tools and encouraging them to share amongst providers, we're really all helping each other then, and in the end, we're benefiting, the patient and hoping to, improve outcomes for them. So just kind of wrapping up here, in the next series of webinars that are occurring, we are going to use the MATCH tool, or Medication at Transitions and Clinical Handoff Toolkit, for medication reconciliation as the basis for our process improvement. And it's a tool that it comes again from the AHRQ, so it's very scientific evidence-based, which is what we're all about these days. It very much correlates to the Plan, Do, Steady Act that many of you may be familiar with, and at Medistar, that's typically the process that we use. So in the MATCH toolkit, they're calling things a little bit different. They're kind of approaching things maybe slightly different, but the intent is still the Plan, Do, Steady Act. And what we're hoping that folks do is print that off, and before the next webinar, which is May 31st, take that information and start to think about how you might start to engage in some kind of process improvement around medication reconciliation at your individual setting. The MATCH toolkit was actually designed for hospitals, but having been in home care and long-term care and hospice and acute care, and actually some even work in physician offices, there's no reason why the information in this toolkit cannot apply, to those other settings and do so really readily and very easily. So I just wanted to make that point. And then we're going to use this toolkit and work through the chapters, kind of a sort of step-by-step, and we're asking that you develop some kind of process improvement strategy, and then actually move through the planning, the designing, the studying, and then the action, the intervention pieces to improve something at your facility. And Jody can be a reference or a resource for you as you're moving through those different webinars and through the different pieces of the improvement process. And what we're asking for is then at each of the different, as you sign up for the individual webinars, the others, the second, the third, and the fourth, we're going to be asking you at certain points along that way to re-answer those 9 baseline questions that have to do with asking you, have you built the project foundation by assembling a process design team? Do you have a charter? Have you determined what the scope of your practice or project is going to be? Have you defined roles and responsibilities? Have you done a flow chart of your current process and you have some idea of where in that process you can affect some change? It's something that you can easily test, something that can be easily spread, to other areas or to, within your organization. And do you have a data collection strategy? And again, we can help with all of those processes along the way. So we're going to use this for us at VESTAR as an intervention evaluation measure for CMS around our ADE work, but this also allows you to develop and plan a project that can meet qualifications for your joint commission, or for if you're in home care or long-term care, for the regulatory guidelines, for any other leadership kinds of things that you might have going on, if your board is interested in those kinds of things. So this work should tie in really well with work that you're really already doing and shouldn't add a lot of extra steps to it, because I think I'm probably about 100% sure that all of you have some kind of process already in place that's designed to do this, because I know in Wisconsin we do really good work across all settings, and we're really engaged and trying to improve patient outcomes and keep people safe. So kudos to all of you for that work. So this should just easily tag into it without creating a lot of extra work. So if you could all review for the next time chapters 1 through 3 in the MATCH toolkit, and again, they're not long, so it's pretty easy reading. And then please sign up for the next webinar, which is May 31st. That would be awesome, and we'll continue our journey to improve medication reconciliation. And I think that really kind of ends what we kind of wanted to talk about today, which is just sort of setting the stage for this further work. So just in summary, I would say that medication reconciliation is really crucial to ensuring safe, effective care. We need to use all of our resources available. We need to engage the patient and ask the patient and talk to the patient on a level of understanding that is very individual to each patient. You could talk to me in one way, but, to my 97-year-old grandma, you may have to phrase things very differently. And I think that's really important. So it's in their own words. That can also help you identify their health literacy, their adherence, adherence to their medication regime, really what their understanding of their diagnosis is, and it can really help you identify gaps. You know, maybe they need assistance being able to pay for their medications. In home care, we saw all the time that people didn't pick up their medications when they were discharged because they couldn't afford it. And that's embarrassing to tell somebody that you can't afford your medications. But we all know that if it comes down to food or meds, what people are going to do. And so nobody should be able to, you have to be put in that situation without having somebody being a resource for them to help them figure out how they can pay for those medications, for example. And it also helps you to identify support strategies that are important for you and what you're able to do for that individual. And maybe it's in terms of getting them hooked up with an EDRC or talking to the physician about, you know, one of the drug programs that they have to get free or low-cost drugs for this particular patient. So I think there's a lot that we have done with medication reconciliation, but I think there's a lot more that we have the capacity and the capability to do. So with that, we'll ask the operator to go ahead, and if there are any questions, we would be happy to answer them at this time. And I'll just reiterate that my contact information is on the last slide, and you are more than willing to contact me regarding any other questions, any resources you want. I have a lot of them, currently working on some for home care and long-term care specifically, but really reach out to me. That's what we're here for, and we really want to support you. So thank you very much.
Thank you so much, Tony.
We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. There will be a slight delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions.
Thank you. And while we're waiting for anyone to put any questions in the queue, I do see that there was a couple questions in the Q&A section. So again, thank you so much for participating. Thank you, Tony. Great job. The slides are available on the website, and we can make sure that those are all available. I do see that there's some concerns that not everyone may have seen them. And so thank you for that feedback. We'll make sure that we get them too.
Yeah, well, I just would like, when you actually registered for the event, and you registered, if you're looking at the screen, to put in the event ID and password was on the right of the screen. If you happen to go down on the left side, there was a link that was entitled like webinar materials, I think, and that's where the slides are or were. So again, if you're not able to retrieve them, let me know. Give me an email and I can shoot those to you if you're not able to get them otherwise.
And that's the same place you would find the 9 questions for that baseline assessment?
I believe so, yes.
Great, thank you. And then there's another question that to be able to do MedRec and bill for it. My screen cut off a little bit.
Operator, are you able to see the questions that we have?
Not the online questions. I'm only able to view the audio questions.
There is a question on what type of degree do you need to have to be able to bill to do MedRec, and if that is required for an RN. And that could have some differences by settings from a regulation perspective.
Absolutely. I guess I would add to that. Typically, in the healthcare settings I've been in, I've seen, for example, in clinics, sometimes it's an RN, sometimes it's a medical assistant that's doing it. In home care, it was typically the RN. Might also be to some extent, an LPN who continues to do that, but typically the RN. In long-term care, it could be, typically the RN or the LPN who's doing the admission. Sometimes if you're the director of nursing, you're also getting, involved in that. I know, though, if you're looking at other settings, it could be a social worker who's maybe, doing that. I think it depends upon any regulations that you're required to follow and understanding what those are, because those really clearly spell out. I think any practice acts that are out there would also, like the RN Practice Act and others. I'm not as familiar with social worker, but you would definitely want to check, those two things. And then again, I think it's, just kind of looking at your setting, and if you would want to email me more specifically offline about some of that question, I might be able to help you a little bit more. It's hard. We're in a difficult situation here because we're not seeing the full set of questions here because of the way the screen is displayed, and I apologize for that. We'll make sure that the next time we have that under control better. So thank you for your patience.
Thank you. So that captures the majority of the questions in the chat. A lot of references requesting the slides and the information. So then please feel free to contact us if you cannot find them in that page. Does anybody have any other questions? We really appreciate your time. We would encourage you to take the extra 12 minutes to go and get that toolkit. Again, feel free to contact us outside of the webinar as well.
So, and again, just to reiterate, see, there's a couple questions. So if you email me offline, I would be happy to send you the slides for sure, and then the 9 questions I can send to you. But in terms of in terms of that, getting the baseline information documented, that would have to occur not from what I send you in the 9 questions, but it actually would have been part of your original registration. That was when, and I think a few other emails have gone out about remembering to complete the baseline assessment questions, those 9 questions. So it's also possible that email could be in your spam folder, or maybe in deleted emails, or ones that you just haven't had time to get to.
Okay, I'm now having Tony's email up on the slide as well, and it is tkettner@metastar.com, metastar.com. Just in case you're not on the WebEx.
So again, I think that there don't seem to be any other questions that at least we can see in the questions on the slide or on the computer. So I think with that, we'll close today's session. And again, thank you all for participating. Thank you so much for the work you're doing in Wisconsin, keeping people safe and in the appropriate setting, and for just trying to improve outcomes overall. It's very much appreciated, and having worked in some other states, I can really kind of say go Wisconsin. So thanks again.
And thank you to those from Michigan and Minnesota too, and the great work that you're doing in those states as well. So we really appreciate your time, and we look forward to having you on the call on May 31st.
Correct.
Have a great day.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.